Hello again, folks, and welcome to the next video, Assessment and Management of Neurogenic Speech Disorders. So changes in speech function can be the first presenting symptom of neurologic disease, and it's our job as speech language pathologists to help identify and manage speech function in these individuals. We might be the first to diagnose a motor speech disorder, differentiate it from a coexisting language disorder, and then help shed light on a possible medical diagnosis or develop a plan of care to manage the deficits. Neurologic speech disorders include motor speech disorders like the dysarthrias and apraxia of speech. They also include other disorders such as neurogenic stuttering, pseudophone accent syndrome, echolalia, palilalia, aprosodia, akinetic mutism, and locked-in syndrome. Motor speech disorders include the dysarthrias and apraxia of speech. And since these are the most common, this is what we're going to focus on. And motor speech disorders are caused by damage to the central and or peripheral nervous system, and they either influence motor planning, motor programming, neuromuscular control, or execution of speech. So here you see some cognitive linguistic processes, which when they're disrupted, they result in aphasia, right hemisphere disorder, cognitive communication disorders. Damage to motor speech planning or programming results in apraxia of speech, neuromuscular execution of speech, damage to which results in dysarthria. So when we're talking about motor speech disorders, we're talking primarily about apraxia and dysarthria. Dysarthria can be broadly defined as abnormal articulation. And this is a term used to characterize neurologic speech disorders that influence neuromuscular control and or execution of speech. It is a collective name for a group of neurologic speech disorders resulting from abnormalities in the strength, speed, range, steadiness, tone, or accuracy of movements required for control of the respiratory, phonatory, resonatory, articulatory, and prosodic aspects of speech production. And the pathologic disturbances in these dysarthria types are due to central or peripheral nervous system abnormalities, and they oftentimes reflect weakness, spasticity, incoordination or discoordination, involuntary movements, or excessive, reduced, or variable muscle tone. Dysarthria can be classified into different types based on perceptual characteristics that reflect the changes in movements. So strength, speed, range, steadiness, tone, accuracy within the various systems involved in speech production. And the 7 dysarthria types are flaccid, spastic, ataxic, hypokinetic, hyperkinetic, unilateral upper motor neuron, and mixed dysarthria. And these are all differentiated by their various perceptual characteristics, pathophysiology, etiology, and lesion location. So flaccid dysarthria results from damage to the lower motor neuron system, including the cranial nerves and spinal nerves. So the most common perceptual speech characteristics of flaccid dysarthria reflect muscle weakness. So when we're talking about flaccid dysarthria, we're talking about weakness. So this can be weakness that affects either phonation, resonation, or prosody in connected speech. So for example, speech might be characterized as breathy, possibly harsh. There might be short phrases in conversation, possibly audible inspiration, hypernasality, imprecise consonants, nasal emission, short phrases. It might be monoloud or monopitch. Flaccid dysarthria can result in damage to the 5th, 7th, 10th, or 12th cranial nerves, so trigeminal, facial, vagus, or hypoglossal. So damage to the trigeminal or facial nerve would result in articulatory and prosodic deficits given bilateral damage. Damage to the vagus nerve would result in breathiness, possibly hypernasality, and then damage to the hypoglossal nerve might result in articulatory or prosodic deficits. And damage that results in flaccid dysarthria can be caused by a number of etiologies. Common etiologies are stroke, tumor, trauma, viral infection, various neuromuscular junction diseases, demyelinating diseases, anatomical abnormalities, and degenerative diseases. Here's a recording from a 52-year-old male who gave permission to use this recording for this class. And he has a diagnosis of progressive bulbar palsy, a history of cleft palate, was reconstructed with surgery, and a history of traumatic brain injury and dysphagia.
The rainbow planets when the sunlight cuts wind gaps in the air. They act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round ox with its past higher and its two ends appearing behind the horizon. There is a coin to the lesson, a boiling pot of gold and at one end. People look, but no one ever finds it. When a man looks for something behind his reach, his friends say he is looking for a pot of gold at the end of the rainbow. Good, that's excellent.
So listening to that passage, can you identify any of the symptoms that we discussed? So spastic dysarthria results from bilateral damage to the upper motor neuron within the central nervous system. Most common perceptual speech characteristics of spastic dysarthria are strained, strangled vocal quality, slow rate, consonant imprecision, which reflect the influence of spasticity and weakness on the respiratory, laryngeal, velopharyngeal, and articulatory components of speech. So speech of spastic dysarthria can be characterized by short phrases, strained or strangled vocal quality, hypernasality, monopitch, monoloudness, and excess and equal stress. Spastic dysarthria can result from a variety of etiologies, including stroke, tumor, trauma, infectious disease in the central nervous system, various degenerative diseases, and demyelinating diseases. Ataxic dysarthria results from bilateral cerebellar damage or generalized cerebellar disease. This is a motor execution and programming impairment. The cerebellum is involved with the timing and coordination of movement. So with respect to speech, the cerebellum is a major regulator of online sequencing and adaptation of overlearned basic speech movements into linguistically larger segments such as words. So the most common perceptual speech characteristic of ataxic dysarthria is slurred, drunk, or intoxicated sounding speech. And this reflects the breakdown of articulatory and prosodic aspects of speech. So ataxic dysarthria may be characterized by imprecise consonants, irregular articulatory breakdowns, distorted vowels, excess and equal stress, prolonged phonemes, excessive loudness variations, slow rate, and monopitch. Damage to the cerebellum can be caused by a number of etiologies, such as stroke, various degenerative diseases, demyelinating diseases, trauma, tumor, and toxic metabolic conditions. Hypokinetic dysarthria results from damage to the basal ganglia control circuit, which is involved in regulating movement. So the basal ganglia regulates movement through excitation and or inhibition of the direct activation pathway and the indirect activation pathway. The direct activation pathway promotes motor activity. The indirect activation pathway decreases motor activity. The most common perceptual speech characteristics of hypokinetic dysarthria include monopitch, reduced loudness, monoloudness, fast speaking rate, mumbling, stuttering during conversational speech, rapid rate of articulation, and short rushes of speech, which reflect impairments in the various speech subsystems. So the term hypokinesia includes akinesia, which is no movement, and bradykinesia, which is slow movement. And this results from decreased direct activation pathway and increased indirect activation pathway activity. Damage to the basal ganglia control circuit results in rigidity in all muscle groups. So this influences speed, range, force, and tone of muscle movements for speech. The most common etiology of hypokinetic dysarthria by far is Parkinson's disease. Now, this is caused by a paucity of dopamine in the substantia nigra within the basal ganglia. So one pharmacological intervention that might be given might be dopamine agonists. So they might be given certain pharmacological treatments that give their body essentially the precursors to producing its own dopamine. So these dopamine precursors cross the blood-brain barrier, and then the brain is able to produce its own dopamine with the additional product. There are other etiologies associated with hypokinetic dysarthria, such as other degenerative diseases, vascular impairments, toxic metabolic conditions, trauma, infectious disease, and normal pressure hydrocephalus as well. Here's an example of a 73-year-old male with a diagnosis of Parkinson's disease, dementia, idiopathic normal pressure hydrocephalus, and dysphagia. He also has a cerebrospinal fluid drainage device in place.
The rainbow passage, when the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into the many, into any. Beautiful backside colors. These take the shape of the long round arch with its bath high above and into two ends apparently beyond the horizon. There is, according to the legend, a boiling pot of gold at the end of each. At the end, people look, but no one ever finds it. When a man looks for something beyond in his reach, his friends say he is looking for the pot of gold at the end of the rainbow. Very good.
So in this example, this shows an interesting interaction between the Parkinson's disease, the dementia, and possibly some of the other medical comorbidities influencing his language, speech, and cognition. Unilateral upper motor neuron dysarthria results from, as the name implies, a unilateral lesion in the upper motor neuron system, which includes the cortex, subcortical structures, the brainstem, the thalamus, and internal capsule. And the most common perceptual speech characteristics include thick, slow speech that deteriorates with fatigue and stress, harsh vocal quality, imprecise articulation, irregulatory articulatory breakdowns, and slow rate. And these are all reflective of changes in the various speech subsystems. Swallowing may also be affected. So one might see drooling, difficulty chewing and swallowing. It tends to be relatively mild in severity and can be transient in some patients, meaning they improve. Common etiologies include vascular disorders, tumors, and trauma. And mixed dysarthria. It's possible that individuals with dysarthria present with multiple kinds of dysarthria, as neurologic disease is not always confined to a specific area of the brain, and it can influence multiple aspects of motor function. So this is a logical thing. So you can have various combinations of the dysarthrias. So you could have a flaccid spastic, ataxic spastic, hypokinetic spastic, etc. There's many combinations that are possible. Common etiologies of mixed dysarthria include various degenerative diseases such as ALS, MS, Friedreich's ataxia, progressive supranuclear palsy, multiple system atrophy, cortical basal degeneration, as these all affect the upper motor neuron and lower motor neuron systems and cerebellar systems. Other etiologies might include toxic metabolic conditions, vascular disorders, trauma, and tumor. Apraxia of speech is a disorder of motor planning and programming. Now, motor planning is sequencing the steps for producing sounds. So that's kind of at the whole articulator level. Motor programming is prepping the speech production system for producing sounds at the individual muscle level. So basically the difference between motor planning and motor programming is one of anatomic structure. So of the whole articulator at the planning level and at the muscles at the motor programming level. So the motor plan specifies the movement goals with respect to the articulators. The motor program specifies which muscles will be used in moving the relevant articulators specified in the motor plan. So apraxia of speech is a phonetic motor disorder of speech production caused by inefficiencies in the translation of a well-formed and filled phonologic frame to previously learned kinematic parameters assembled for carrying out the intended movement, resulting in intra and inter-articulator temporal and spatial segmental and prosodic distortions. This is essentially describing the nuances of the motor planning and programming disorder known as apraxia of speech. So apraxia of speech can be characterized by various distortions of the segment and intersegment transitionalization, basically the transition between segments. So in apraxia of speech, you get a slow rate of speech. So this could manifest as extended duration of consonants, vowels, and the time between sound syllables and words. You might get sound distortions, such as substitutions. You might get prosodic abnormalities, such as misassignment of stress and other phrase and sentence level prosodic issues. Errors are typically consistent in location and invariable in type, although some data suggest variable error type. And there are also other errors that are more or less associated with apraxia of speech classically, such as articulatory groping, perseverative errors, increasing errors with increasing word length, speech initiation difficulties, awareness of errors, more errors in propositional speech, and islands of error-free speech. In its pure form, which is rare, it is not attributable to deficits in processing of auditory, tactile, kinesthetic, proprioceptive, or linguistic information. So the purpose of assessment in motor speech disorders is to describe the salient features of the patient's speech, determine the severity, indicate, confirm, or question the neurologic diagnosis and localization, formulate a prognosis, identify treatment goals and potential treatment tasks, and document change over time. And the methods by which we do this are auditory or perceptual, acoustic, and physiologic. So auditory perceptual is known as the gold standard because the presence or absence of a speech disorder is based on perception. And acoustic data and acoustic analysis provides information about the acoustic signal, which is kind of the gestalt, kind of the result of the whole system. And then physiologic, you can look at individual subsystems to a certain extent. So first, one might gather a detailed history. This might include diagnostic history, surgical history, the patient's prior level of function, the timeline of onset, was it abrupt or gradual? The progression of the disease, is it improving, declining, is it stable? You might look at the imaging results, CT, MRI, SPECT. If the patient had previous speech therapy, what were the therapeutic methods employed? Was there a documentation of improvement with particular methods? What's the patient's education, their occupation, their marital status? How many children do they have? How does the problem affect their communication with novel and known partners in a variety of different communicative environments? And all of this information can be used to make predictions regarding the diagnostic accuracy and the prognosis. You might utilize non-speech tasks, such as an oral mechanism exam, a laryngeal function assessment, a respiratory function assessment. And in these, you will observe carefully with purpose the patient's speech mechanism, and always have to know why you're examining each component. What is it that you're trying to look at? So within an oral mech exam, you might look at the face at rest, and observe for symmetry, If there's maybe a droop on one side, you might look for abnormal involuntary movement of a particular facial structure, a tremor-like movement, fasciculations might be present. You might look at the face during sustained postures or during movement. Looking at lip retraction, rounding, puffing of cheeks, sustained mouth opening. You might look at the jaw at rest for the presence of abnormal involuntary movements, the jaw during sustained postures and at movement. You might look at the tongue at rest during sustained postures and at movement. And you might look at the velopharynx at rest and during movement. Now, the tongue in particular, as it is the articulator with the greatest degrees of freedom, you might look specifically for its mobility along a number of different dimensions. Maximal protrusion, its ability to lateralize from one corner to the next, both steadily and quickly. You might have them hold it on one corner and then the other corner and then go back and forth slowly in a more controlled manner and possibly more quickly. You might have them try to touch their nose with their tongue. So you're looking at elevation, and you might have them try to touch their tongue with their chin. So it's kind of descended downward. You might have them lateralize the tongue in their mouth against the inside of their cheek and press against your finger and kind of feel the strength on both sides. You might actually use a tongue blade and have them press upwards as you put the tongue blade against the dorsum of the tongue and kind of feel their ability to elevate the anterior, medial, and posterior portion of their tongue. You might have them puff out their cheeks. You might have them spread and round their lips. So any number of these types of tasks, kind of looking at the ability to perform various motor movements that might be relevant for speech. These non-speech tasks allow for isolation of movements of individual articulators that cannot be done in speech tasks. And so you might want to evaluate the face, the mouth, the tongue, the palate at rest, during sustained postures, during movement, and during reflex elicitation. So you're looking for strength, symmetry, range, tone, steadiness, speed, and accuracy. And all these terms are defined here for you. Strength is, although it's defined in the J&J as it's kind of a definition of endurance that they give you. Really, it's more the capacity to exert force on physical objects. So it's more of a magnitude of force concept. With symmetry, we're looking at kind of right-left symmetry of the face at rest and during movement. With range, we're looking at how far a structure can move during a task. With tone, that's the continuous and passive partial contraction of muscles of the oral structures. So perhaps the tongue is more bulky on one side or the other. So it looks like just at rest, it has a greater amount of muscle tone on that one particular side. That might be an indication of unilateral paresis. You're also going to look at the steadiness at rest or during movement. You could check for tremor, for example. You're going to look at the speed that the structures are able to move and the accuracy of movement. So you can also look at a variety of non-speech tasks examining the phonatory and respiratory system function. And these help determine the kind of the relative impact of the various subsystems. And deficits here might be due to weakness, incoordination or discoordination, involuntary movements, or possibly maladaptive strategies that the patients have adopted to kind of compensate for the initial impairment. And so relative to the phonatory system, a true evaluation of voice requires instrumental assessment with flexible transnasal endoscopy and rigid stroboscopy. However, you can look at a number of things without it. So you can look at adduction via volitional cough, aspirate onset versus hard glottal onsets, their ability to produce breathy versus pressed quality during sustained phonation. You might examine their mean pitch and loudness. Are these maybe the optimal pitch and loudness for them? Their ability to volitionally modulate pitch. So you might look at pitch glides. You might look at the presence or absence of tremor. You might perform an acoustic perturbation analysis with acoustic analysis equipment. And you might do the same thing with loudness modulation. So looking at their ability to produce variations of loudness, such as a messa di voce, so crescendo, decrescendo kind of thing, getting louder, getting softer. Presence or absence of tremor. You can also perform an acoustic perturbation analysis. The phonation duration, various duration measurements, and you could do an acoustic and aerodynamic assessment as well. You can look for nasality, either too much or too little, hyper or hypo, respectively. You can look for nasal emission, so audible emission of air through the nasal cavity. You can look at the respiratory system. So you might be looking at you might perform a respirometric analysis. You might measure their vial capacity or their forced expiratory volume in 1 second, or a variety of other respirometric measurements. You might look at their posture while seated and see if that influences their breathing. You might just examine their breathing at rest. Is there audible inhalatory stridor? Maybe that could be indicative of vocal fold paresis or paralysis, or maybe even a subglottic stenosis of some kind. You could look for abdominal and thoracic movements. Where is the range of motion located in their breathing? Like how are they breathing? Are they breathing clavicularly? Are they breathing thoracically? Are they breathing abdominally? You can look for shoulder and neck movements during respiration. And you can also kind of think about various interactions between the various speech subsystems. So relative to elicitation of reflexes, this is done because some reflexes can disappear given nervous system damage. So therefore, it might give some, therefore examining the reflexes to see if they are present or not, this might give some information regarding confirmation of a lesion location. So your textbook lists a few reflexes here: the gag reflex, the jaw jerk, the sucking reflex, and the snot reflex. So the gag reflex has a airway protection function, and this is elicited by stroking the posterior tongue, the fascial pillars, or the posterior pharyngeal wall with a swab. And this examines how intact the glossopharyngeal and vagus nerve are. Sensation would be picked up by the glossopharyngeal nerve, and the motor output, the gag, would be triggered by the vagus nerve. And so a lack of this reflex might indicate a defect, a deficit in either the 9th or the 10th cranial nerves. But note that it is absent in about 1/3 of adults, so you do kind of have to interpret the absence of this gag reflex with caution. The jaw jerk is another one. It's a primitive dynamic stretch reflex, and this is absent or very slight in most adults. So this tests the integrity of the trigeminal nerve. So the patient has a slightly open mouth position, and you tap the lower jaw just below the lips. And so this is a stretch reflex. The idea is that you stretch the masseter, and then the reaction is then the mouth closes. So give an intact jaw jerk. The sucking reflex and the snot reflex are both infantile reflexes, and they do disappear after 1 year of age. However, you do see them in adults with frontal lobe disease. So you might see this with some adults with dementia, encephalopathies, closed head injuries, and hydrocephalus. So auditory perceptual assessment of speech characteristics and intelligibility. You might listen to the speech during natural discourse, make decisions regarding salient speech characteristics. So what is their articulation, their phonation, respiration, resonance, prosody like? Some limitations of this method is that there is no isolation of the various subsystems. You're looking at the whole system altogether. Assessment does require a certain amount of training, and there are issues with inter-rater reliability. How close together a variety of ratings are. You can break this down in terms of the tasks that are used during the auditory perceptual assessment. So you could look at simplified speech tasks, citation tasks, or language formulation tasks. Simplified speech tasks include prolonged vowels, such as a maximum phonation time task, diadochokinetic rates, such as alternating motion rates and sequential motion rates. So AMRs are things like pa 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 pa, ta 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 ta, ka 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 ka, and sequential motion rates are paraka 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 paraka. So With AMRs, it's repetitive CV syllable, and normative values are 5 to 7 reps a second for pa and ta, and 4 to 6 reps a second for ka. With SMR, the kind of the trisyllabic sequence, normative values are 3.5 to 7.5 repetitions per second. And if the patient has a difficulty with pa ta ka or pa ta ka, you could do something like buttercup or patty cake as well. Here are two examples. Here is the patient with progressive bulbar palsy. All right, so whenever you're ready, pa 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 pa.
Pa 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 pa. Pa 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 pa.
Very good. That's good. That's very good, buddy. Thank you. And the next one is pa ta ka.
What?
Pa ta ka.
Pa pa pa.
Yeah, pa ta ka.
Keys
Keys
are
are
hard for
hard.
me.
Yeah, because that's that raising the tongue up
Yeah.
thing, right? Just do the best that you can.
And the same way with TH.
Yeah, absolutely. Same sound is really difficult for you.
Yeah.
So let's just do the best that you can.
Pa pa pa.
Yeah. Okay, so start going and I'll tell you when to stop. Okay?
Pa pa pa. Pa pa pa. Pa pa pa.
Thank you. Very good. And the gentleman with Parkinson's disease.
Am I ready for a cue?
Yeah, you're ready. Very nice. Good job. Next one. Pataka, pataka, pataka. As many times as you can. We'll go about 10 seconds here.
Paraka, 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 paraka.
Very good. That's it. Nice job. Thank you. Okay. There's also citation tasks. So this could include stress testing, such as counting for 2 to 4 minutes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, just counting continuously for 2 to 4 minutes. Various motor speech programming assessments, such as repetition of phonemes, CVC words, words of increasing length, multisyllabic words, days of the week, sentences, so some of those automatics. And then there's language formulation tasks. So these are contextual speech tasks. So things such as spontaneous conversation, narrative discourse, reading passages such as the rainbow passage, grandfather passage, the Cape V sentences, that sort of thing. So perceptual ratings are subjective ratings given by a clinician, oftentimes done on just on a simple number scale, possibly a Likert type scale, where you rate a variety of different variables along a continuum. And so one perceptual rating scale that exists is the dysarthria rating scale, which is based on the Mayo Clinic dysarthria studies used to determine dysarthria type. And with this scale, one measures the normalcy of various variables here. So 0 would be normal, 1 would be mild, 2 is moderate, 3 is marked, 4 is severely deviant. And you can use a plus or a minus sign to indicate excessive or decreased amounts, magnitudes. So you could have, you would look at pitch, loudness, voice quality, resonance, respiration, prosody, and articulation on this 0 to 4 scale. You'd also look at intelligibility and bizarreness as well. A standardized test for motor speech disorders is the Frenchet dysarthria assessment, 2nd edition. And this is the only standardized measure designed for measurement, differential description, and diagnosis of dysarthria. It's a 9-point scale with 8 different areas that are rated. Reflexes, respiration, lips, palate, laryngeal, tongue, intelligibility, and influencing factors. This has a high inter-rater reliability. There's also the apraxia battery for adults for apraxia of speech. And this is the most commonly used standardized measure for apraxia of speech. It assesses the presence and severity of apraxia of speech in both children and adults. There are 6 subtests assessing the performance of patients on a variety of tasks, such as the diadochokinetic rate, words of increasing length, limb and oral apraxia, latency time, utterance time for polysyllabic words, repeated trials test, and inventory of articulation characteristics for apraxia. There's a variety of intelligibility measures, which characterize the degree to which an individual is understood when speaking. So these are these gross measures of, well, how well is this person understood? This is useful kind of for defining the baseline performance, setting treatment goals, and assessing change over time. And so now we're just examining kind of the whole speech mechanism, the result of the whole speech mechanism. So the acoustic signal. And this is pretty ecological because it assesses how natural speech is understood in context. One intelligibility measurement is the assessment of intelligibility of dysarthric speech, the AIDS assessment, which assesses intelligibility during single word and sentence production. So 50 words and 20 sentences with a length of 5 to 15 words each. Words and sentences are audio recorded and transcribed. And the clinician then rates intelligibility, speaking rate, the rate of intelligible speech, and what's known as the communicative efficiency ratio. There are subjective perceptual voice quality measures that exist as well. So the GERBIS by Hirano and the CAPE-V, which was created by the ASHA SIG3 group. So with the GERBIS, you're looking at grade, roughness, breathiness, asthenia, and strain. That's the GERBIS name. So grade is the overall degree of the voice deviance. Roughness refers to irregular fluctuation of fundamental frequency. Breathiness is the turbulent air produced by air leakage. Asthenia is the overall weakness of the voice. And strain is the impression of tenseness or excess effort. Strain is notoriously difficult to define and to measure, by the way. The GERBIS is on a 4-point scale and requires about 8 hours of training for proficiency and good reliability. The CAPE-V, the Consensus Auditory Perceptual Evaluation of Voice, has 5 variables within it: the roughness, breathiness, strain, pitch, and loudness. And there's generally good agreement of SLP ratings on both the GERBIS and the CAPE-V. So here is the CAPE-V with this Likert-like scale with mild, moderate, and severe kind of anchors along the line. First, you perform sustained vowels on ah and e for 3 to 5 seconds. And then you perform these sentences. The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak. And then spontaneous speech in response to, tell me about your voice problem, or tell me how your voice is functioning. And then the clinician rates each of these components along this scale from mild, moderate to severe, and then gives a numeric score from 0 to 100. And then you rate the consistency or the intermittency of the various aspects. And you can also add other components, such as presence of diplophonia, fry, falsetto, asthenia, aphonia, pitch instability, tremor, wet, gurgly voice, or any other relevant terms which you would like to add. And then you might add comments about resonance as well. There are self-ratings of voice, the VHI, the VHI-10, the VRQOL. So the voice handicap index is a very popular one in which the patient rates how their voice is functioning, how it physically works, and their emotions about their voice, these 3 different subcomponents here. So it is a self-rating of voice in the functional, physical, and emotional domains. And a score is provided. And it's a criterion referenced scale. And there's also the Voice Handicap Index 10, which is kind of a reduced version of the VHI that has good validity with the VHI original. There's also the voice-related quality of life measurement. And it's similar in the sense that it rates individuals' function, emotions, and the physical working of the voice. And there's also this index, the Voice Disability Index, that is also sometimes used. Measures of communicative effectiveness. There is one known as the Communicative Effectiveness Survey that evaluates changes in communicative effectiveness during social participation. And this provides questions about the patient's ability to converse with familiar and unfamiliar communication partners across a variety of settings. It has been studied in Parkinson's and traumatic brain injury patients. And interestingly enough, it was found that intelligibility was not significantly related to perceptions of communicative effectiveness. There may be other factors that are influencing the person's communicative effectiveness other than just intelligibility, such as injury severity and the neurologic disease, although one would expect that intelligibility would be determined by injury severity. So this was an unusual finding. Here are a variety of selected acoustic measurements. So acoustic measurements are useful because the acoustic signal contains information that is a product of all speech subsystems. So this gives you kind of a overall picture of the voice, kind of a gestalt kind of a view, a forest versus the trees view of the voice. But you're also able to analyze things, analyze individual aspects of the signal quantitatively, exactly, and then you're able to compare things numerically to kind of determine if there's any differences across time or between groups, for example. Deficits observed in the exam can be measured with objective acoustical analysis techniques. So you might look at consonant imprecision, you might look at durational measures, you might look at the spectra of various consonants, like fricatives, for example. You might look at formant transitions. You might look at distorted vowels. So you could look at formant frequencies and transitions. You could look at reduced vowel space area where you're measuring the formants of corner vowels and looking at the vowel space in a F1, F2 plane. Typically with individuals with Parkinson's disease, the vowel space area is lower versus neurotypical adults. You might look at hypernasality, where you would see a low F1 frequency, you would see a low intensity formant, spectral zeros, you might see nasalence. You might look at, you might observe monopitch or monoloudness, so flat FO contours or intensity contours, respectively. You might look at various phonatory disturbances, harshness, strain, and attempt to quantify that in a variety of different methods. Maybe perturbation measures might be used, such as a jitter or shimmer, kind of the cycle-to-cycle variability in the period and amplitude of vibration, respectively, in the auditory signal. And then you might look at signal versus noise type measures, such as noise to harmonic ratio or signal to noise ratio, or you might look at cepstral peak prominence or smooth cepstral peak prominence. You can look at speech timing, so a variety of rate measures, speech rate, artic rate. You could look at pause time, segmental duration measures, such as voice onset time or vowel duration. And I've included here, there is a free software known as Prod, which if you're not familiar with it, it is a wonderful software analysis tool that is free, and they have both Mac and PC versions. So a few selected physiologic measurements. So these provide additional information about the various subcomponents of the speech mechanism, and they oftentimes will require specific equipment though. So you could look at pressure, perhaps subglottal pressure via a YouTube manometer, or you could look at volume metrics, such as with a spirometry, airflow via a pneumotachograph, rib cage movements, laryngeal muscle activities versus laryngeal muscle activation via electromyography, vocal fold contact area via electroglottography, a vocal fold vibration via endoscopy or stroboscopy, tongue palate contact area via palatography. You could look at vocal fold function via flexible endoscopy. You look at swallowing function via a modified barium swallow study, or you could look at a FEES, a flexible examination, flexible endoscopic evaluation of swallowing. You could look at tongue strength. You could look at jaw and lip muscle activation via EMG as well. So these are all very useful physiologic measurements of voice and speech, which can give you information about the deficits in the speech system. So management of neurologic speech disorders. So first, to identify the deficits in the assessment. So you look at the respiratory, phonatory, articulatory, resonatory, and prosodic aspects. And then based on the nature of the deficit or the type of dysarthria, the patient may be a candidate for one type of treatment approach or another. So the respiratory system is the power source. So deficits in the respiratory system might result in decreased control and coordination of the respiratory system. The phonatory system is a sound source. So deficits here might result in decreased control, coordination, or phonatory function. And the articulatory and resonatory system provides the filter characteristics. So the location, and so the center frequency and the bandwidths of the various formants. What is the formant structure? And deficits here might yield decreased control, coordination, and or function of the articulatory resonatory system. And I should note that oftentimes when people are referring to resonance, they're typically, sometimes they're talking about hyper and hyponasality. So they're kind of referring to the side branch, the nasal cavity. Resonance is a function of the entire vocal tract. So resonance, sometimes people will look at it in a limited way and refer to resonance as hyper or hyponasality, when in actuality, resonance is more of a general concept that kind of interrelates with articulation. And prosody refers to suprasegmental aspects of speech, such as intonation, stress, and rhythm. So prosody is more of a broader concept. And so deficits in any of the above subsystems can result in a deficit to prosody. There are a variety of non-speech and speech tasks that can be used to target the respiratory system and train the patient to increase strength, coordination, and or control, or compensate for the dysfunction. So your book provides a number of non-speech and speech tasks here. So non-speech tasks for respiration might include controlled exhalation tasks. So you're exhaling on for example, a S phoneme for 10 seconds, 20 seconds, 30 seconds. You might do maximum inhalation and exhalatory tasks, various pushing and pulling techniques, which might also influence adduction, breathing against resistance, exercises, sustained phonation with visual feedback, and inspiratory or expiratory muscle strength training with, and there are a number of devices that are used for inspiratory and expiratory muscle strength training that you may have seen used by athletes. There are also speech tasks that are often used. So deep inhalation before speaking. So kind of preparing the breath prior to speech. Increased force on exhalation during speech. So using increased expiratory muscle force. Inspiratory checking, which is this recruitment of inspiratory muscles to control the force of expiratory muscles and maintain consistent airflow and subglottal pressure during speech and voice production. And then choosing optimal breathing points, so optimal breath groups for phrases or sentences, maybe within a paragraph. You can also examine the patient's posture to determine if there is any impact of posture on speech. For example, slouch posture might result in decreased expiratory support. An upright posture might reduce the pressure on and restriction of abdominal movement for speech breathing. Like I mentioned before, it is good to determine where they are breathing from. Are they using mostly a upper chest, kind of a clavicular breath? Is that where the primary range of motion is? Are they breathing from the ribs? Are they kind of breathing kind of out into the side more? Or are they breathing primarily with a belly breath, kind of an abdominal movement that occurs during breathing? So examining the location of their breath and how the breath is affected by posture. So management of phonatory dysfunction in motor speech disorders, you will oftentimes want to address hyper, too much, and hypo, too little, adduction. And so this manifests as a strained or a breathy quality, respectively. So with hypoadduction, you have weak, kind of breathy voice quality, incomplete glottal closure. That's very, very breathy. You might address this with exercises for increasing adduction, such as phonating while pushing, maybe against a desk or a surface, or pulling. You might use controlled coughing, like try to cough and then sustain the cough, kind of a thing where you're sustaining the cough. Things are being brought together. You might start the phonation at a higher respiratory volume. So you're beginning speech at the top of the breath, so to speak. You might trial the effect of various postural manipulations on adduction, and this has to be done with care. If there's training for laryngeal manipulation that is done, so I'd say be careful with this. Don't do this unless you really unless you have received training. But there can be some digital laryngeal manipulation techniques that can be done. Head turning to one side or the other might change adduction, and that might be an indication that surgical modalities such as medialization on one side might be useful, because if the head is turned to one side, that might bring that one side closer to midline. Lee Silverman voice treatment, LSVT, LSVT loud, increases the loudness of speech, and it's primarily used in individuals with Parkinson's disease for increased loudness, but it can also increase glottal closure. And you will want to address hyperadduction if it's present. So this manifests as a strained quality. And in these individuals, you might focus on reducing tension, muscle relaxation, improving phonatory control. So easy onset, breathy onset, maybe self-monitoring techniques, biofeedback techniques, maybe laryngeal massage, progressive whole body massage, maybe a touch of phonation type exercises. So where you start out with and you gradually begin phonation. I should note that another thing that you can do with patients with voice disorders is if they are hyperadducted or hypoadducted, you can use what's known as negative practice. And with this, you have them do one extreme and then the other extreme, and then you have them try to find the middle ground. So if you had a patient with hypoadduction, so they're really breathy, you might have them be even more breathy. And then try to increase it all the way to the maximal extent on the other side. So they're really, really, really pressed. And then try to find the middle ground. So this is really breathy. This is really, really pressed. Now try to find the middle ground. Okay, here's middle ground. Okay, one extreme to the other. So kind of negative practice, finding the switch, finding one extreme, then the other, and trying to find the middle ground. With various phonatory disorders, there are some prosthetic devices that might be used as an adjunct to other therapy modalities, such as portable amplification devices. These are oftentimes used in teachers that are having voice disorders. Then when they have to project to an entire classroom full of students, that may be a noisy environment. And there's actually one particular device that your book mentions called a Speech 5 system, which is kind of interesting. It uses the Lombard effect to cue for louder speech. So the patient has an accelerometer on their neck. Kind of it measures vibrations, at their sternal arch, and they have an earpiece in place. So given a soft voice, which is picked up by the accelerometer, it's like a microphone. Given a soft voice, the accelerometer picks up a too soft sound, and then an earpiece in response plays back background noise in the patient's ear that causes the speaker to increase their vocal loudness. The kind of the idea of the Lombard effect. When you're speaking in a loud room, you increase your loudness. Well, it kind of capitalizes on the Lombard effect. So it's kind of an interesting strategy. Then there's also surgical interventions that can improve vocal function, such as vocal fold medialization surgery that might have to occur if there's some paresis or paralysis on one or both sides. Injections to kind of bulk up the vocal folds. For example, if there is a bowing, such as in the case of presbyphonia or old voice, Botox injections for individuals with spasmodic dysphonia. I worked in a clinic, an ear, nose, and throat clinic in Philadelphia for 2 years, and I got to see a variety of different voice and ear surgeries. And I also got to see Botox injections, and I have some. I'll talk a little bit about that during the voice section, but this was a very, very interesting procedure to examine. And there are actually some pharmacological therapies that are starting to come out for spasmodic dysphonia. One is sodium oxybate, Xyrem, which is used for spasmodic dysphonia. And this Professor Simonyan has done some very excellent research on that. She's kind of developed this whole pharmacological treatment, it's really amazing. I went to a talk that she did earlier this month in Philadelphia, and it was absolutely amazing, the research that she's doing relative to pharmacological treatments in spasmodic dysphonia individuals with individuals with spasmodic dysphonia. Okay, management of VP dysfunction. So this oftentimes refers to hypernasality or nasal emission. The patient might have an inability to build up sufficient air pressure for production of stop consonants, and subsequently they will have reduced intelligibility of consonants. And in terms of behavioral management, this is typically done with people with mild deficits, not moderate to severe deficits. People with moderate to severe deficits or structural anatomical issues will likely require prosthesis, various prostheses and possibly surgical intervention. So behavioral management methods include slowed rate, which might improve velopharyngeal timing, increased effort, which might improve VP closure, strength or resistance training. For example, a CPAP, continuous positive airway pressure device, can be used for soft palate resistance training. So basically, the CPAP is on the face with airflow going through the nose, which forces the soft palate to remain open, and then the patient must contract muscles to try to close the VP port. And there's some research evidence that there's some positive effects of this in muscle resistance training in TBI patients. You can also use biofeedback for airflow detection, such as a dental mirror. Here you can kind of see the mirror fog up under the nose when there's airflow going through it. Warm, humid air going through the nose. You could use a paper strip or an air paddle, such as this, to kind of, or a tissue paper to observe. You could use that as feedback for the patient, so they can see the paper rattle or the tissue fluctuate with airflow. You could use a straw in one nostril and have the patient feel themselves, or you could feel the airflow through the nose, or a C-scape airflow device, such as this one. It's kind of like a little rotometer or an airflow device with a little straw going through it, so the ball raises as airflow goes through it. Or on the high tech end, a nasal flow transducer could be used. There are various prosthetic approaches. So a prosthodontist might fit a palatal lift, which it covers most of the hard palate with a narrow portion that kind of extends to the soft palate to try to improve VP closure. It kind of helps prop it up a little bit. So candidates for a palatal lift should have soft palate flaccidity, adequate speech, cognitive, and swallowing function, adequate dentition, and sufficient manual dexterity to remove the prosthesis. And it would be better if they had stable or slowly improving or worsening speech characteristics. Rapid changes in patient function, the prosthesis might just become obsolete quickly because their function is changing so quickly. So they were just fitted for this prosthesis that can be relatively expensive, and it's well, if they have it now, they can't use it anymore because it's obsolete, right? And there's surgical approaches such as the superior pharyngeal flap. Management of articulatory dysfunction and motor speech disorders. Behavioral management methods isolate the articulatory system using a variety of methods. One method is integral stimulation, in which the clinician provides visual and auditory models for a particular target with fated prompting over time. Phonetic placement is another, where the clinician guides patient articulator placement directly via a variety of descriptions, illustrations, models, and demonstrations. There's phonetic derivation, in which case the clinician starts out with a speech or non-speech gesture that the patient can produce well as a starting point, to then shape articulators into the proper position for another sound that the patient's having trouble with. So for example, if the patient had difficulty with sh, but was able to produce s well, one might start anterior and move the tongue posteriorly. So facilitating a good sh. That's difficult for a patient with an intact s. There are also instrumental biofeedback techniques, such as electromyography, which can be used to reduce hypertonicity and spasticity in a variety of articulatory muscles and improve patient speech. Oral motor exercises or strengthening exercises can be used to strengthen specific articulatory muscles during non-speech tasks. I will say that oral motor exercises for speech are somewhat controversial, as the literature does not always report the intensity, speed, duration, dynamics, frequency, and/or progression of exercises used in the various studies. And data is limited that increasing articulatory strength will improve articulation. So just increasing articulatory strength alone may not actually improve articulation. It could be coordination or range of motion or some other variable that's actually primarily responsible for the decrease in articulatory precision. But this might be appropriate if the patient is presenting with a flaccid dysarthria characterized primarily by significant weakness, right? Also, stretching or range of motion exercises can also be useful for the same reason as the strengthening exercises. Just here, we're looking at range of motion versus strength generation. Management of prosody. So LSVT is one therapeutic modality that's relevant to prosody, as LSVT focuses on increasing loudness, and prosody includes stress patterns, so intonation and stress. Stress is controlled primarily by pitch, loudness, and duration. So loudness is a primary factor in stress, and stress is a part of prosody. So LSVT can influence prosody. LSVT has an intensive schedule, so 4 times a week for 4 weeks, so a lot of therapy, and it requires high respiratory and phonatory effort. It requires special clinician training and certification. It has been shown to yield improvements in both respiratory, phonatory, and articulatory function in Parkinson's disease patients. And it's one of the few therapy modalities for motor speech disorders that has really good efficacy data. So LSVT it has a lot of research behind it. There's also rate modulation. So decreasing rate permits more time for the articulators to transition from one sound to the next. And various tools that can be used are things like pacing boards and alphabet supplementation. So pacing boards provide visual and tactile prompts for slowing the rate, and it tends to increase articulation and intelligibility. Alphabet supplementation is very similar to pacing boards. It's kind of a variation on pacing boards, and it requires the speaker to point to the first letter of each word spoken on an alphabet board. So this will slow the speech rate and provide first letter prompts. There's also contrastive stress drills, such as Mike is going to the store. Mike is going to the store. So you can contrast which word has the primary stress. You can see that changing those turns, and in that particular example, it changed it from a statement to a question, depending on the stress and the trajectory of the pitch, the intonation across the sentence. And you can also use, this is kind of related to negative practice too, in the way that you're using contrast to get the patient to kind of find the switch, to find the control switch for that particular variable. You can also train the patient to breathe or pause at syntactically appropriate times. That might improve prosodic aspects. One thing that I use clinically, it's a very simple model, SOS. Speak loud, over-articulate, speak slowly. And so that really gets to the loudness variable, the articulation variable, and the rate variable in such a way that the patients have a minimal amount of things that they have to remember or contend with. And typically I will have them do one at a time until when they really have that one aspect down, like for example, loudness or rate or articulation, then you can look at another one, and then you can try to combine the two together, given enough practice, and do the same thing adding the third. Looking at the third one individually and then combine it to one of the previously learned ones. So this kind of gives you a sequential way of looking at variables, of adding speech variables that are likely to improve patient overall intelligibility. You can also look at the use of clear voice. So a prompt for clear voice is read the sentences as clearly as possible by enunciating well, as if someone is having trouble understanding you. Just asking a patient to speak clearly with this type of a prompt might actually improve intelligibility a significant amount. It's worth a shot. Another thing that I use sometimes for loudness is speak as if you're trying to talk to someone across the hall. That might be another useful prompt. So in management of apraxia of speech, you can use articulatory kinematic treatment. And the goal here is improvement of spatial and/or temporal aspects of articulation utilizing principles of motor learning for successful acquisition of treatment targets. So this can rely on integral stimulation, like we discussed earlier. So you're using auditory and visual articulatory prompts. So this is kind of like the traditional behavioral technique, right? And there's one 8-step approach that's described by Rosenbeck, where you're basically systematically reducing the level of the prompting. So you start with simultaneous production of the target, so maximum production. The clinician and the client are both simultaneously producing the target. And then there's faded prompting, delayed imitation, where the clinician presents it first and the client presents it right after that. Then imitation with multiple successive production. So the client produces the target once, and the patient produces it a number of times. So a few of those are kind of by themselves. And then you can use printed stimuli of targets without auditory or visual articulatory prompts. So you just have the picture. And then you can have printed stimuli with delayed production. So you present it and then you have a delay and then they produce it. And then response eliciting questions. So you ask them a question where the response would be the word in question, the target word. And then there's kind of a response eliciting role play scenario where you're kind of role playing. It's more of an ecological type situation where the target response has to be produced in the context of something closer to a conversation. So you can see this is a systematic reduction in the level of prompting. There's also another few articulatory kinematic therapy types that your book mentions: sound production treatment and modified response elaboration training. And they both kind of rely on integral stimulation. And then there's articulatory placement prompting. And this facilitates correct placement of the lips, the jaw, the tongue for each sound. And this can be utilize drawings, videos, and clinician models. And there is one particular type of articulatory placement prompting that has been developed that's relatively structured, relatively systematic, called the prompts for restructuring oral and muscular phonetic targets. The prompt, that's a quite cute acronym for that method. So this is a structured approach with auditory, visual, tactile, and kinesthetic prompts via finger placement on the face and neck to provide information regarding place, manner, voice, jaw movement, sound duration, etc., for a variety of target sounds. A drawback of it is it requires a lot of training for the clinician, but there's good target accuracy for the patients. Once you work on a target with the prompt method, tends to be that the target is acquired accurately. Unfortunately, there's poor generalization to non-targeted sounds. Also, with apraxia of speech, you might look at modulating rate and rhythm. So you can focus on slowing the speech rate to allow for additional time for planning and programming, motoric planning and programming. You could utilize a metronome, a pacing board, or use computer-controlled presentation of stimuli. This tends to improve articulation, reduce rate, and increase fluency, although the evidence for this particular type of therapy is somewhat limited for motor speech or for apraxia of speech. And there's also augmentative and alternative communication, AAC methods that can be used for populations, for patients with comorbid apraxia of speech and aphasia. So this is obviously a compensatory method. So we're not trying to rehabilitate the system. We're just trying to compensate for the deficits, find some other alternative modality. So you could train multiple modalities in addition to speech. So writing, drawing, and gesture. There will be a significant amount of training to both the patient and the patient's communication partners, their family, the caregivers. And you could utilize picture word communication books, alphabet supplementation, a variety of dedicated speech generating devices and tablets. So all of the various AAC devices that we discussed previously. All right, and that does it for this lecture. Thank you so much for watching, and I will see you next time.